the Epley maneuver today. This is used for something called benign positional vertigo. When we talk about vertigo, it's a sense that you're moving when you're not moving. And a lot of things can cause it in medicine. We want to make sure it's not a stroke is the most important thing, or some other brain tumor. Most of what I see, though, ends up being benign positional vertigo. The symptoms of benign positional vertigo is often it just comes on out of the blue. Biggest story is people often just wake up with it. They turn their head to look at the alarm clock and they're like, whoa. And then they stop, and usually within a minute or so or less, it starts to settle down. Often the queasiness doesn't go away. Then they sit up and like, whoa. And then they feel it again. And then they don't know what's going on, so they lie back down. It's like, whoa. Then they look over, and it's like, whoa. Every time they move, they have no idea the fact it's the movement of their head that is causing it, but they will get the sense that things are moving when they're not moving, even though they are not moving. So the diagnosis, we do a physical exam to make sure there's nothing else going on. Vertigo that is persisting, that isn't just for a minute or less, and that is, or that's lasting longer, that doesn't have other features like problems swallowing, problems hearing, facial droop, weakness on one side of the body, all of those things you need to use to separate. So if you have a history, and I have a history that somebody has benign positional vertigo, they've had an exam, we've ruled out all these other things on exam. This is something that can be done to help alleviate this. It's called the Epley maneuver or repositioning. What happens is in the inner ear, not only is the ear actually for hearing, but the ear is to help with balance. If you are standing and you or being spun around as a kid, you can know if you're upside down, being spun, you know what position, even if you can't see with your eyes or feel with gravity, you can actually have this. There's 3 semicircular canals, and within them there's fluid. These canals at the center of hairs that little stones on them, and that when you move, the fluid moves these, and the brain is able to sense these through the fibers that which position you're being spun in, if you're upside down or whatnot. What happens is these stones can get out of position. Normally, the fluid in these canals swooshes around, and there's a pop-off valve, so to speak, called a round window. That's the elastic membrane. It bends, and it softens the blow. What happens, these stones can get into the way, so when you turn your head, the fluid sloshes, and it hits that, and it rebounds back. So you get this, imagine if you had a tube that instead of was curved, was bent, that was 2 hard ends. You went like this, you could see in the plastic, and there would be waves going back and forth. That's why within usually a minute, it settles down as long as you keep your head still. The waves go back and forth. What the hope is with this repositioning is that we can turn the head around so that that stone floats back in its normal position. This often has to be repeated. Hopefully when done correctly, about 80-90% of the time, can improve, sometimes has to return. So, you don't probably have an exam room at home, so this is going to simulate being on the ground or being on a couch, but our ground is very hard, so we're going to do this. I have a pillow in the back here. It's going to hit right in the middle of the back. So what we want is the head to take about a 30-degree drop. So with a pillow here, that's one option. I'm just going to straighten this table out here that we have that. Going to bring her legs so she's sitting right on the edge of the bed. So you start with the head turned to the left. That's the first position. And then what we're going to do is have her turn her head quickly towards me. Turn your head quickly. And I always say keep the eyes open when I'm doing this. I can see if somebody's eyes are moving. Hold this for about 20 seconds. And her eyes aren't moving. She's thinking.
I'm watching your shirt.
She's watching at my shirt. There's not a lot to watch here, and sometimes in a room like this you can't tell. But when I'm doing this with somebody, I can actually like keeping their eyes open. And then we'll have the pillow here. We always keep your head turned to this side. Okay, then we'll have you lie down. Keep your head turned here. And then I'm looking again. I keep an eye on her eyes. Obviously, if you're doing this at home, you can't keep an eye on your eyes. But your spouse, friend, family may be able to keep an eye on that.
Not too bad.
And we're taking a look. She says not too bad. Her eyes, she doesn't feel anything. In fact, I don't see her eyes moving back and forth. That's called nystagmus. So that's the inner ear getting a signal that's not that is.
Okay.
So we're taking a look. I'm going to have her quick turn her head to the left. Now, one of the things that we have on a day like this, we're not going to be doing this, is the next step we're going to have her turn on her side, and then she's going to get on all fours. Now, one of the things about all of this is if people who have benign positional vertigo may have a queasiness in their stomach. Okay? So she's going to turn on her side now. She's going to kind of get on her side, and then in a little bit she's going to turn on all fours. People who get benign positional vertigo and are prone to motion sickness, which, by the way, if you're prone to motion sickness, often there's a personal history or family history of migraines or tension headaches, which are really a spectrum of the same thing. So she's going to kind of get on all fours here. And like I said, we're not going to do this on the floor. If you are at home, you would be laying flat if this is the end of the day. This isn't the end of her day, so we're going to wait another 20 seconds. We'll have her then scoot so she's sitting on the edge of the table here, so bringing her left and her butt and her feet, body facing beyond the edge of the table here. That's another option that we can do to try to help alleviate this. This often can be repeated more than one time. This partially or not completely helps. So you just kind of sit. And hopefully this will help. Like I say, about 70-80% of the time this will help alleviate the symptoms. This often has to be repeated more than once. There's anticholinergic medications. Anticholinergic is the effect of acetylcholine on the body. Benadryl is an anticholinergic. Meclizine is a over-the-counter one that can help. That does not cure anything, because all it does is, what the problem is, these stones called otoliths. Oto means stone, so these ear stones are in the wrong position. We have to reposition it. What the anticholinergics like meclizine and Benadryl do, all they do is dampen that signal from the inner ear that goes to the brain. So hopefully this will help you understand a little bit more about what benign positional vertigo, one of the most common causes of vertigo,